Welcome to HBV APASL Reactivation 2021 Guideline. I'm Professor Masao Mata from Tokyo, Japan, and I'll be co-chairing the session with Professor Shiv-Kumar Sarin from New Delhi, India. Our first speaker is Professor George Lau, who will be presenting on historical perspective. Professor George Lau is currently the chairman of Humanity and Health Medical Group, Hong Kong, and chair professor and director of the HIFS Medical Center of Chinese PA General Hospital, Beijing, China.
Yes, good morning, everybody. Can you see the slides? The slide. Yes. So thank you to Professor Omata and Professor Sarin for chairing these sessions. And I want to thank the panel with all the members and working parties for their hard work over the past year for developing this HBV reactivation guidelines. The first talk is on the introduction and historical perspective. And I think this is important because we all need to learn from history and to understand the previous success and failures and to translate into the future, taking into what is happening right now at this moment. On behalf of Professor Misukami, who has kindly sent his slides, I would give the talk together with him. He is not available because he is now tied up with the COVID-19 and with the new biomarkers discovered to be predictive of COVID-19, and it will be announced very soon. There is no conflict of interest. The reasons why we are formulating this HBV reactivation guidelines is under the decisions by the steering committees with Professor Sarin and Professor Omata. And despite the decades of basic and clinical research and the multiple guidelines, unfortunately, hepatitis due to HBV reactivations remains a major health threat in Asia-Pacific regions, where HBV infections is endemic. And this is not surprising that a lot of these patients have acute and chronic liver failures, as alluded by Professor Sarin's excellent guidelines and literature publications. In addition, the recent expanding use of new immunosuppressive agents, oncological agents, and also DAAs therapies for chronic hepatitis C and biological agents in various treatments paradigms is imposing the new challenges to these problems of HBV reactivations. Unfortunately, in the year 2021, fatal hepatitis due to HBV reactivation still occurs, despite all the guidelines and effective therapies to prevent it from happening and the managing of these patients. And so, in fact, I show you here one slide which was published by the Analogs groups some years ago. So even in US, the HBV reactivations in patients receiving immunosuppressive therapies remains unchanged over decades, after the introductions of nucleoside and nucleotide analogs, which is very effective in preventing fulminant hepatitis due to HBV reactivations. This slide is from the Professor Misukami, which shows that from the PubMed search, you can see the literature related to HBV reactivations keeps on increasing. It's not only in the journals of gastroenterology and hepatology, but also infectious diseases and general medicine, transplantation, surgeries, immunology, hematology, and also recently with the new oncological therapies in combinations with the RNA vaccines and so on. So it is not a problem which is diminishing despite our understandings, because there are new agents coming in. And very unfortunate, even in Hong Kong, where we have a lot of understandings and the publications related to HBV reactivations, we still encounter the unfortunate cases who died of hepatitis B reactivations. This is a very famous story in Hong Kong, young mothers with lovely families who suffers from HBV reactivation. She has IgA nephropathy, giving high-dose steroids without preemptive NUC therapy, and subsequently have acute or chronic liver failure. And she had 2 liver transplants, but unfortunately she died. So we are still seeing the tragic stories from time to time, despite the efforts of 20 years of having all the guidelines and the ways to prevent it from happening. The main objective of these guidelines is really, we want a broader perspective. We want to bring this attention to our other colleagues, because as a hepatologist, we usually see these patients when they already have the problems, but the problems need to be prevented when they are being seen by somebody else, such as a medical oncologist, as a hematologist, interventional radiologists, transplant surgeons, rheumatologists, and nephrologists. So we want to write the practice guidelines, which will be the comprehensive and can bring attention to our colleagues in other medical specialties, in addition to our hepatologists. A panel was being set up, me, myself, together with Professor Yuming Nong, Professor Grace Wong, and Professor Alice Thompson, and so with the panel members and for the discussions of the recommendations, review of the literatures, and gradings of the evidence. With 4 decades of clinical research, we have a lot of understandings on the incidence and risk factors, pathogenesis, and some of them, some of the good, well-designed clinical study and the standardizations of the nomenclature. So some of the history, I think that we need to bring attention, especially to the youngcomers. This paper was published in 1975, and some of our panels were not even born at that time. But the stories of HBV reactivation started since then. This is a landmark paper published at that time, 45 years ago, or 46 years ago, on an 18-year-old male with acute lymphoblastic leukemia who had hepatitis B antibody early in the course, but subsequently developed the Hep B antigens, where at that time we we do not have the assays to differentiate clearly E antigens or surface antigens, and they have liver failure after chemotherapy. This paper was published in 1992, which shows the reactivations of chronic hepatitis B infections patients after receiving the chemotherapy for the cancer therapy, published by J. Hove-Nagel. And it shows that even asymptomatic surface antigen carriers, when they receive such therapies, they run the risk of fulminant hepatitis due to HBV reactivations. And it is clearly demonstrated on the serial monitoring of all the HBV markers and the liver biochemistry. In 1991, in Hong Kong, when Analog is still with us, she published the first prospective studies in a group of lymphoma patients who received cytotoxic chemotherapy, and it was clearly shown that those patients who are surface antigen positive run a much higher risk of hepatitis due to HBV reactivations than those who are surface antigen negative. And the recommendation at that time was that they should be closely monitored. Some of these patients with HBV reactivations died with hepatic failures when they received cytotoxic therapies for their malignant lymphoma. So this is the first prospective studies ever conducted. And subsequently, I have an opportunity when I work in primary hospitals to report the first case of hepatitis due to reactivations in patients with bone marrow transplantations, which is made available in Hong Kong in the early 90s. So we are seeing the new cases because of new form of therapy. And in this case, it's the allogeneic bone marrow transplantations in patients who have acute leukemias and receive allogeneic bone marrow transplantations. You can see that during chemotherapy and when the patients receive this, the bone marrow transplantations, there is an rising of HBV DNA based on serial monitoring of the DNA levels, followed by the elevations of ALTs, and the patients suffers then from the fulminant hepatic failure and die. Well, since then, we have the opportunity to understand whether we can prevent this from happening, because the DNA is a rise before the ALT rise, and it happens on the withdrawals or on the chemotherapies or immunosuppressive therapies. And in the early part of this century, so the 21st century, nucleoside analogs were made available, and at that time it was lamivudine. So we are the first groups to be able to, in collaborations with Professor Phil Johnson in Chinese University, to conduct a randomized studies to understand whether the patients with lymphoma, when they are placed on chemotherapy, could benefit from the prophylactic use of lamivudine versus those who will not receive a prophylactic. And it is demonstrated that prophylactic lamivudine use, that is the nucleoside analogs only available at that time, to clearly shows the beneficial effect. So preventing the hepatitis due to HBV, the reactivations. This is further supported by other subsequent studies, which is randomized control trials with the use of entecavir, and in those patients who received rituximab R-CHOPs for the surface antigen negative anti-HBC core positive cases. So these are the 3 randomized control trials on the prophylactic therapies in preventing HBVRs in lymphoma patients. Meta-analysis subsequently was also performed and shows that prophylactic therapies is effective in solid tumors which was treated with cytotoxic chemotherapy. Well, this slide was from the Professor Misokami. He wants me to show this. This is the first report of HBV reactivations by Jeff Dushekos in 1983. In a group of patients who received renal transplant, and it shows that from the serological data, the hepatitis due to HBV reactivations was probably is more likely to be related to ongoing infections rather than de novo infections of HBV. Now, so this beautiful figure was performed by Professor Misokami, which shows this way for HBV reactivations and importance of anti-HBs. And in the 1983, in the groups of renal transplant patients, and then by analogs in our centers, primary hospitals, and then by Durfitz published in New England Journal of Medicine in 2001, followed by our work in primary hospitals and also the Chinese universities. And recently by Paul, we published in Hepatology, which shows an increasing the awareness and importance of even patients who are surface antigen negative but anti-core positive with anti-HBs. This paper was published by our groups, which is the first ones to show that patients who has occult HBV infections defined as surface antigen negative, anti-core positive, but HBV DNA positive by the sensitive nested PCR based on 3 regions, and received the rituximab containing the chemotherapy that could suffer from the fatal HBV reactivations. And these patients eventually recover, fortunately, with the use of lamivudine. But we don't want this to happen. Recently, with the use of direct-acting antiviral agents, our groups are together with the Beijing 302, the military hospitals. So we studied prospectively a group of patients who were co-infected with hepatitis B and hepatitis C who received the DAAs. And we demonstrate that hepatitis due to HBV reactivations could happen, and sometimes it could be very lethal, so with fulminant hepatic failure. So coming back to the timelines and the logistic of the development of HBV reactivations, The process reports to the panel and the audience. We start in Boston in 2019, the 9th of November, by a group of panelists and the chairmen and co-chair, with areas covers being decided and how the methods of the guidelines was done. And then we have the divisions of labors on the various topics, the literature search, section drafting. Unfortunately, the work was pretty interrupted by the COVID-19 pandemic. And then we start, so we pick this up again under the guidance of Professor S.K. Sareen, who wants us to really carry on. And thanks for his encouragement, and also Professor Mata. We and now here to give you the recommendations after the serious discussion and circulations of all the evidences and of relevance. This is the conflict of interest that all of us will comply and agree upon. And the grading evidence and recommendations was adapted from grade. So each recommendations will be given a grade, evidence, and also the strength of the recommendations. Well, obviously, there are other factors which affect the governments and the public officials, despite the availabilities of the recommendations, such as the prevalence of the health problems, the ease of implementations, considerations of equality, total cost to the society, and also the potentials for improvements of in the quality of care. I'm really honored to be part of the APASL, the big family. Our consensus formulation started in 1999, and this is the old pictures, and this is the faculty members for the first consensus for the treatments and diagnosis of chronic hepatitis B and C. Some of our colleagues, many of them are my teachers and my good friends, such as Professor C.L. Light, and you can see Professor Okuda is here, and some of those colleagues have left us. But then our work should carry on, and I look forward to have young people and young spirits to continue our work as APASL. Thank you very much.
Thank you, Sareen, a co-chair. I have distinct pleasure in inviting Professor Alex Thompson, who will be speaking on pathogenesis and risk factors in HBV reactivation. Professor Thompson is an outstanding hepatologist and an asset to the world. He is the Director of Gastroenterology at the Department of Gastroenterology of St. Vincent's Hospital and the University of Melbourne, Australia. Welcome, Alex.
So can everyone see my title slide?
Yes. Yeah.
Terrific. So good afternoon, everyone. My name's Alex Thompson. This afternoon, I'm presenting on HBV reactivation, pathogenesis, and risk factors. I'd like to thank the organisers and APASL for the opportunity to present this talk, and also to be part of the committee that's reviewing and developing the APASL guidelines for the management of HBV reactivation in the setting of immunosuppressive treatment. These are my disclosures. Today, I'm talking about the pathogenesis and risk factors of HBV reactivation in the setting of drug treatment, and specifically treatments that suppress the immune system. HBV reactivation has been well described in the setting of treatments for hematological and oncological malignancy, in the setting of hematopoietic stem cell transplant, solid organ transplant, as well as increasingly immunosuppressive treatment for chronic inflammatory conditions, including the inflammatory arthritis, inflammatory bowel disease, and psoriasis. HBV reactivation can be defined as a logarithmic rise in HBV DNA level, or in isolated anti-core positive patients as seroreversion from HBs antigen negative to anti-HBs positive status, and that occurs in the setting of immunosuppressive treatment. The typical time course, as highlighted on this slide, is for HBV DNA to rise first during the period of immunosuppression itself, with later risk of hepatitis and ALT rise as the immune system reconstitutes after the immune suppressive treatment is stopped. This hepatitis is associated with risk of clinically apparent liver disease, and in more severe cases, jaundice and the risk of acute liver failure. And this risk of clinically apparent liver injury can persist for up to 12 to 18 months following the period of immunosuppression. The pathogenesis of HBV reactivation relates to the inhibitory effect of the immunosuppressive treatment on key pathways that are involved in the immune response targeting HBV. Key mediators of HBV clearance include the T-cell response, including both the cytotoxic HBV-specific CD8 response, as well as the cytokine-mediated non-cytotoxic response. The B-cell response, involving production of neutralizing anti-HBs antibodies, is also very important, as has been, and also the innate immune system, more recently recognized. So immunosuppressive treatments targeting these key pathways can lead to HBV reactivation, as highlighted in this excellent diagram from a review article by Lumba and Liang published in Gastroenterology in 2017. We see B-cell depleting agents and proteasome inhibitors that affect the B-cell response. Cytokine and chemokine inhibitors, now often used for treatment of chronic inflammatory diseases. T-cell targeting drugs such as the immunophilin inhibitors cyclosporin and tacrolimus, as well as JAK-STAT kinase inhibitors. Cytotoxic chemotherapies can affect both T-cell and B-cell responses. We have integrin inhibitors such as vedolizumab, used for the treatment of inflammatory bowel disease as well as rheumatological conditions. The TNF inhibitors and kinase inhibitors that are important in inhibiting the innate immune response. The risk of reactivation is greatest in patients who are surface antigen positive, but there is also risk in surface antigen negative, anti-HBC or core positive individuals, where the immune response has not been potent enough to eradicate all of the niches of infected hepatocytes harboring either latent HBV-HCC DNA or low-level replicating HBV that's escaped targeting by the HBV-specific immune cells. The key determinants of HBV reactivation therefore include the hepatitis serous status, surface antigen positive versus anti-core positive, the immunosuppressive regimen itself, which I'm going to speak in more detail about. Host factors are important, both the underlying disease being treated, for example, lymphoma, the disease pathology involves immunosuppression itself. Cirrhosis status is also very important because this determines the risk of poor outcome rather than the risk of reactivation per se. And then a very key clinical point is that antiviral prophylaxis prevents HBV reactivation. This is why we're trying to identify these patients and make a decision about which patients require prophylaxis. So the key risk factors, let's talk about the key risk factors and the immunosuppressive regimen itself. So cancer chemotherapy, both hematological malignancy, both treatment for hematological malignancy, especially B-cell targeting drugs, anti-CD20, anti-CD52, solid organ chemotherapy can be associated with HBV reactivation. Hemopoietic stem cell transplant is associated with a high risk of HBV reactivation. Solid organ transplant is also associated with risk. I'm going to talk less about solid organ transplant today because there are well-published protocols for management of hepatitis B in the peri-transplant period. And then, as noted, the new anti-inflammatory treatments for chronic rheumatological inflammatory bowel disease and the chronic inflammatory dermatoses. The American Gastroenterological Society published a very helpful technical review in 2015, where they classified risk of HBV reactivation into high, greater than 10%, medium, between 1 and 10%, and low, less than 1%. Patients were classified as either surface antigen positive or surface antigen negative, but anti-HBC positive. The highest risk agents for reactivation were noted to be the anti-CD20 therapies, such as rituximab, as well as hemopoietic stem cell transplant. And note that it is these two categories of patients that are also associated with the highest risk in surface antigen negative, anti-core positive patients. Anthracyclines such as doxorubicin are associated with a high risk of reactivation, as is longer-term high-dose steroid therapy. Medium risk of HBV reactivation is associated with anti-TNF therapies, particularly the more potent adalimumab and infliximab. Anti-cytokine therapies, including ustekinumab and vedolizumab, now used to treat inflammatory bowel disease. Tyrosine kinase inhibitors, the immunophilin inhibitors, cyclosporin and tacrolimus, as well as proteasome inhibitors. Another very useful resource is this recommendation developed by the European Conference on Infection in Leukemia, or EASL, and published in 2015. They drew similar conclusions, where patients were categorized as surface antigen positive or surface antigen negative anticore positive. Surface antigen positive patients being treated for hematological malignancy were felt to all have high risk of reactivation, and you can see that antiviral prophylaxis was recommended for all categories, both stem cell transplant and CD20 therapy, where the risk of reactivation was greater than 50%, as well as lower risk categories such as methotrexate. The surface antigen negative anticore positive patients, the highest risk, and the highest risk therefore requiring prophylaxis, was associated with stem cell transplant and anti-CD20 treatment. To conclude my talk, I want to talk about a number of special situations. I want to ask now the question, in surface antigen negative anticore positive patients, does anti-HBs matter? Both the presence or absence of anti-HBs as well as the titer of anti-HBs. So firstly, the presence of anti-HBs. There is a risk gradient for core positive patients for risk of reactivation according to whether anti-HBs is positive or negative. And in the data I present, HBV reactivation the risk was lower, 4.3% in patients with detectable anti-HBs, compared to patients where anti-HBs levels had waned, where the risk was 12%. However, most of the studies in this area are small, and the risk of HBV reactivation was still clinically significant at 5% in those patients who had detectable antibodies. Well, what about anti-HBs titer? Again, the effect of anti-HBs titer on hepatitis B reactivation has not been reported in many studies. I present data here from a study of 29 patients being treated with R-CHOP for lymphoma. 8 patients lost anti-HBs and 1 developed reverse hepatitis B seroconversion or seroreversion. None of the 10 cases in this study with a pre-treatment anti-HBs level of greater than 100 became anti-HBs negative or reverted, and reactivation did not occur in these patients. So there is a signal for anti-HBs titer to be clinically important, but this data has not yet been replicated, and I don't think we should be making clinical decisions based on one small study. So the conclusions I draw from these data is that the presence of anti-HBs does not eliminate the risk of HBV reactivation, and there is insufficient evidence to support the use of anti-HBs titer in making a recommendation regarding prophylaxis. I want to talk about a number of special situations. Firstly, TACE. TACE is used to treat intermediate stage HCC in patients with hepatitis B infection. TACE has been associated with HBV reactivation, and many of these patients will have cirrhosis. These patients therefore should all be treated with antiviral therapy, both to prevent hepatitis B reactivation, to optimize liver function, to maximize treatment options, and also potentially to reduce the risk of HCC recurrence. Secondly, treatment of hepatitis B co-infections, hepatitis C, hepatitis D, and HIV can be associated with HBV reactivation. Treatment of hepatitis C with DAAs has been associated with HBV reactivation, and there is now an FDA black box warning associated with DAA therapy in North America. There is an important risk gradient between surface antigen positive patients and surface antigen negative anticore positive patients who have a much lower risk of hepatitis B reactivation. And it's important to note that in the West, where hepatitis C is associated with injecting drug use, anticore positivity is common. Oral antiviral therapy for hepatitis D has been associated with HBV replication, and this was noted in the lonafarnib clinical development program. The risk is lower in the setting of interferon therapy for hepatitis D, which is of course active against both hepatitis D and hepatitis B. And in HIV, treatment with non-HBV active heart is associated with risk of HBV reactivation, and fulminant and fatal HBV reactivation has been described. Therefore, patients with HIV hepatitis B co-infection should be treated with HBV active heart. What about herbal and dietary supplements? Well, there are no published data to inform recommendations at the moment, but the risk of HBV reactivation is thought to be low. A particularly challenging area currently is how do we manage new anti-inflammatory immunosuppressive agents? This can be difficult, and I think case-by-case decisions should be made based on the mechanism of the new agent, clinical trial data, and the clinical scenario in point. An example is the checkpoint inhibitors. These are increasingly used to treat patients with advanced HCC. Based on their mechanism of action, activating the immune response, HBV reactivation is unlikely. On the other hand, because of concern about immune activation leading to severe exacerbation of hepatitis B and interruption of treatment for HCC, antiviral prophylaxis has been recommended for HBV-infected patients undergoing checkpoint inhibitor therapy. So I want to conclude now. The risk of HBV reactivation is greater in surface antigen positive than surface antigen negative anticore positive patients, but there is a risk in anticore positive patients. Both the potency and mechanism of immunosuppression are important for determining the risk of reactivation, and the highest risk reported in the literature is associated with B-cell therapies, as well as hematopoietic stem cell transplants. Patients with cirrhosis have a higher risk for poor outcomes, and therefore a liver fibrosis assessment is important in hepatitis B patients being treated with immunosuppression. And very importantly, from a clinical perspective, antiviral prophylaxis prevents HBV reactivation. Thank you.
Our next speaker is Professor Myung-Lung Yu, who will be present on risk stratification. Professor Myung-Lung Yu is a visiting staff at the Hepatobiliary Division, Department of Internal Medicine of Kaohsiung Medical University Hospital, Taiwan, Taipei.
Good morning, my friends. I'm Myung-Lung Yu from Kaohsiung Medical University, Kaohsiung, Taiwan. This is my discussion. The annual incidence of hepatitis B flare in natural history ranging from 1% to 4.53% in the HCI studies. The key risk factors for HBV reactivation including the host factors, the HBV biological factors, the type of and the degree of immunosuppressant, such as male sex or age, presence of cirrhosis, and type of diseases. And the positivity of surface antigen, DNA level, E antigen, anti-S antibody, and co-infection with HCV, HIV, and HDV. B-cell depletion therapy, such as rituximab, is the most powerful, most risk for the of immunosuppressant related to HBV reactivation. And cycling derivatives, median or high dose of prednisolone for more than 4 weeks, and TNF-alpha inhibitor are also with risk of HBV reactivation. So currently, the HBV reactivation has been stratified into 3 groups. The high-risk group is the rate of HBV reactivation of more than 10%, including the surface antigen positive patient receiving B-cell depleting agent and cycling derivatives, and median or high dose of corticosteroid for more than 4 weeks. Or for the surface antigen negative anticore positive patients who receiving B-cell depleting agents are also at a high risk of HBV reactivation. For the moderate risk, ranging from 1.1% to 10% of HBV reactivation, including surface antigen positive patient or surface antigen negative anticore positive patient who receive TNF-alpha inhibitor, the other cytokine and integrin inhibitor, receiving tyrosine kinase inhibitor, or the surface antigen positive patient with low dose of corticosteroid for more than 4 weeks, or for the patient without surface antigen with anti-core antibody, receiving medium or high dose of corticosteroid for 4 weeks, or receiving anthracycline derivatives. And the other are low risks. So here I would like to summarize the published data in Asia Pacific for the HBV reactivation without NUC prophylaxis in different populations of different type of disease and different type of immunosuppressant. For certain antigen positive patients with hematologic malignancy, the rate of HBV reactivation was around 53% in lymphoma patients with or without steroid-containing chemotherapy, and 62% for the patients with hematologic malignancy, and 100% for the patients receiving hematopoietic stem cell transplantations. For patients with receiving TKI, the average HBV reactivation rate was 14% in subcutaneous positive patient with hematologic malignancy. So how about the patient with solid organ malignancy receiving chemotherapy in subcutaneous positive patients? 23% of HBV reactivation rates in breast cancer, and 32% of in the hepatocellular carcinoma patients underwent a test, or 36% for those receiving systemic chemotherapy. For certain antipositive rheumatoid disorder, most of these patients are treated with anti-TNF-alpha, and the average rate of HBV reactivation was 22%. And for patients receiving tocilizumab, the rate of HBV reactivation was 100% in the 3 patients, and 2 patients have decompensation. And for certain antigen negative patients with hematologic malignancy, the rate of HBV reactivation was only 3% for lymphoma patients receiving non-rituximab containing chemotherapy, but up to 17% for the lymphoma patients receiving rituximab containing chemotherapy. For subcutaneous negative hematologic malignancy patients, the HBV reactivation rate was 2.4% for those receiving from the data from Taiwan. But for the patients receiving hematopoietic stem cell transplantations, the rate of HBV reactivation was 6.7%, remain up to 29% for the patient even had HBV vaccination, but only 0% for the patient receiving TKI. For those subcutaneous patients with rheumatoid disorder receiving anti-TNF-alpha inhibitor, the rate of HBV reactivation was 3.1%, and only 1.6% for those receiving tocilizumab. Recently, the advance in the immune checkpoint inhibitors have introduced this regimen to many kinds of the cancer, and raising the critical issue whether this agent will result in the HBV reactivations in surface antigen positive or in HBV result infection patients. So here is some preliminary data demonstrating that for surface antigen positive patients receiving immune checkpoint inhibitor, the average HBV reactivation rate was 14%, but 0% in the surface antigen negative patient from recent data in Taiwan. And talking about the rituximab, the anti-CD20, is a very important factor associated with the increased risk of fulminant hepatitis B in acquired HBV patient. In this study, including 244 patients, 20% of the acquired HBV infected patients developed fulminant hepatitis B, and most importantly, the key important factor is the rituximab containing regimen with an hazard ratio of 16. And also the presence of anti-HBs is also very important in the risk of HBV reactivation among patients with resolved HBV infection underwent hematologic hematopoietic stem cell transplantation or chemotherapy. In these two studies, you can see for patients without anti-HBs at baseline of a patient with without HBV infection, the risk of HBV reactivation was significantly higher than those with anti-S at baseline. Whatever in the patients of the lymphoma receiving rituximab, or for the patient of leukemia with stem cell transplantation or chemotherapy. And in these studies, meta-analysis data demonstrated that the anti-S seronegativity is a very important risk factor associated with the HBV reactivations in the patient with resolved HBV infection, especially among the patient with rituximab-containing chemotherapy or among the patient of lymphoma. The recent approval of the immunotherapy in hepatocellular carcinoma have also raised the issue that whether the HBV reactivation will be induced by the immunotherapy. So this study includes 6 patients of HBV-related HCC without prophylaxis or NUC, and demonstrated 1 patient experienced HBV reactivation followed by LT flare, indicating that this is an emerging issue in the era of immunotherapy for hepatocellular carcinoma. Another important issue recently is the wide use of the interferon-free DAA in the treatment of HBV-HCC co-infected patients and for the patient of HBV mono-infected patients with resolved HBV infection. So this slide summarizes the average rate of HBV reactivation among HBV-HCC co-infected patients treated with interferon-free DAA. As you can see, the average rate was 41.1%, and 7.1% have HBV hepatitis. For the patient with resolved HBV infections treated with interferon-free DAA for HCV, the rate of HBV reactivation was very low, only 0.6%. So talking about the risk of HBV reactivation in HBV-HCC co-infection, as you can see, the baseline surface antigen level play an important role. Those patients with surface antigen level less than 10 IU have a significantly low risk of HBV reactivation compared to the surface antigen level greater than 10 IU per ml, 18% versus 42%. So this highest HBV reactivation rate was also confirmed when compared to the matched HBV mono-infected patients in the natural course, indicating the DAA treated patient will induce a significantly higher risk of HBV reactivation after the HBV eradicate. But interesting, in our patient, 10% of the patient will have surveillance lows 1 year after end of DAA therapy. But when using the surface antigen level at 10 IU per ml, you can find the patient at high chance of surface antigen lows if they have a surface antigen level less than 10 IU per ml, 26% versus only 2%. However, when compared to the matched HBV mono-infected patients in the natural course, the chance of the HBV surface antigen loss were comparable between the two groups, indicating this like the natural course in the patient with surface antigen level less than 10 IU per ml. So here I would like to update the risk stratification of HBV reactivation. In the high-risk group, I suggest either the patients HBV-HCC co-infections receiving DAA is a high risk in the meta-analysis and prospective study, except for the patients who are non-cirrhotic and have a surface antigen level less than 10 IU per ml. The other moderate to high risk group for the patient who receiving immune checkpoint inhibitor or receiving tyrosine kinase inhibitor for the surface antigen positive patients. There are no change in the moderate risk group, but for the low risk group, the DAA therapy for HBV-HCC co-infection for non-cirrhotic patients with surface antigen level less than 10 IU per ml would be the low risk group. And also the tyrosine kinase inhibitor and DAA for HCV infections for patients who have a resolved HBV infection, the risk of HBV reactivation are also very low. There are some uncertain groups. We have to follow study, including the surface antigen negative anticore positive patients receiving immune checkpoint inhibitor. Thank you for your attention.
Thank you very much for this excellent talk, Professor Yu. We keep the session for questions later. May I invite Professor Grace Wong for management and monitoring?
Okay, thank you so much, Professor Serene. Good morning, ladies and gentlemen. So I'm truly honored to be part of this management guideline committee, which is a very important guideline. I think that will really guide the management of our patients. And I'm so glad that the previous speakers have so excellent overview of the situation that will kind of make my job much easier. So I'm going to review some of the management guidelines up to last year. In fact, I would say that in many of the international guidelines, they also touch on that, but probably not as detailed. So I think this reactivation guideline dedicated to this very special situation would be really helpful. There's some of my disclosures. In fact, previous speaker already touched on that. So I just briefly go through that. When we manage our patients, we have to check for their serology, I think like surface antigen, and in some special cases, like Professor Yu just mentioned, some very potent immunosuppressive therapy, we may also need to check the anti-HB core antibody and anti-HBs. And there would be different situation here. If both the antibodies are negative, then in fact, these patients would be susceptible to the Hep B infection. If the anti-HB core is positive, then in fact, these patients have a previous HBV infection. And if only anti-HBs without anti-HB core, it can be either past infection or due to immunizations. So we need to check for their immunization status, like the year of birth as well, whether they have immunized. And this has been repeatedly emphasized that in fact, antiviral therapy would be very helpful to really greatly reduce the risks of HBV reactivation during chemotherapy. I think the evidence is already very strong. And also, in the old days, we used lamivudine, and in recent years, we have more potent antiviral drugs like entecavir, which, as well as tenofovir, like there would be a handful of studies already showing that using these drugs can really reduce the risk of HBV reactivation from patients with either known HBV infection or even just past infection. And in this, already touched on, in fact, rituximab is something that really potent immunosuppressive therapy that can bring up some reactivation, even the patient already have resolved hepatitis B reactivation. So I think in such setting, like if we know that the patient is HBs antigen negative but anti-HB core positive, we still have to put them on effective prophylaxis. Like in this study, they put on entecavir, and this would greatly reduce the risk of HB reactivation. So when we review the guidelines, the three major international guidelines for hepatitis B, in fact, they also touch on this part by recommending what kind of serology test we should order as a screening. I would say it's quite similar that we have to check for surface antigen, and anti-HB core is also recommended because in some very potent immunosuppressive therapy that can also lead to reactivation in past HBV infection. And obviously, if the patient is surface antigen positive, then no doubt we should treat them with antiviral agents. And for those with surface antigen negative but positive for anti-HB core, then again, we should treat for high-risk therapy, like just like highlighted in previous talk, rituximab, stem cell transplant. In fact, some guidelines may also offer another alternative is to monitor the HBV DNA. So maybe we can monitor like every few weeks or 3 months to see if there's a trend of increasing of HBV DNA become detectable, then we can also check. But I think nowadays in some parts of the world, because antiviral agent has become generic and the cost is maybe even lower than checking the HBV DNA. So in fact, myself probably would choose to treat these patients because it will be safer and also may save the cost of regularly monitoring HBV DNA. And concerning the choice of drugs, I think nowadays there's no doubt we will use the first-line potent antiviral agents like tenofovir and entecavir. We can choose either TDF or TAF, depends on the availability of the drugs. And how long we should put the patient on these agents. In fact, I think minimum would be at least 6 months after the end of the immunosuppressive therapy or chemotherapy. But in some situations, some guidelines may recommend a bit longer, like 12 months, which in fact, this is the way that I'm doing in these days. And even EASL guideline may recommend even longer, like up to 18 months for rituximab, because this is something that really potent that can have residual immunosuppressive effect. Like here, this old but very important study showing that even we have already given antiviral therapy to the patients, and some patients after stopping the drugs, like have consolidation therapy for a few months here, in fact, some of them may still relapse after the end of the prophylaxis. And the important risk factors or predictors will be the baseline HBV DNA, because that reflects how active the HBV infection is. So in fact, we still need to keep an eye on the patients even after the consolidation therapy for 12 months or 18 months. We still need to monitor the liver function and HBV DNA regularly. And we still have to remember that some patients, they may need antiviral therapy regardless of all these immunosuppressive agents or chemotherapy. It's just that because they had those diseases, then they bring the patients to us. So we still need to review whether they have pre-existing indications like high ALT to start with, high HBV DNA, and some sign of cirrhosis or significant liver fibrosis. So in fact, this is also we need to bear in mind. So a very simple summary, then surface antigen positive, then we need to review whether they have existing indication. If that is the case, just start the drugs and treat them like a regular happy patient, just keep them on long-term treatment. But if they do not have all those indications, like they have normal ALT, low HBV DNA, no fibrosis, then we will see how long they need the prophylaxis. And I think nowadays we still choose tenofovir and entecavir as our preferred drugs. And for those with past HBV infections, then we would check their antibodies for the surface antigen and core antigen. If both antibodies are negative, then we may consider HBV vaccination after the end of the immunosuppressive therapy. For past HBV infections like positive anti-HB core, then you may monitor HBV DNA or put them on treatment. And the other cases will be anti-HBs positive, anti-HB core negative. Then again, you may also monitor the HBV DNA, and if those antibody is not due to vaccination. And I briefly touch on fibrosis assessment because, as I mentioned, in fact, if for patients who already have pre-existing advanced fibrosis or cirrhosis, they may need the treatment anyway. We should not stop them. So we may consider to use like some serum panels to assess the severity of liver fibrosis. Or these days, many big centers already have FibroScan. So I think FibroScan is another option that probably will be more convenient to check is there any advanced fibrosis. And usually we may use this algorithm. It depends on the baseline ALT. If baseline ALT is normal, then we use 9 kPa, and high ALT up to 5 times, we use 12 kPa to define advanced fibrosis. So in such case, we would not stop antiviral therapy because they need the long-term treatment anyway. And this very nice figure also show kind of the algorithm of what we should do. We need to evaluate the risk, like what Professor Yu nicely demonstrate, is it high risk, moderate risk, and low risk, and check the serology, do liver fibrosis assessment, and then depends on the risk level, and then to offer appropriate management. I would say that nowadays, because in many parts of the world, we have generic drugs. So in fact, in any case, if we have any doubt, in fact, I think put them on antiviral prophylaxis would be something that would be the safest approach. So with that, I thank you very much, and I look forward to more discussion during the Q&A session. So thank you very much.
Thank you, Professor Wong. I see Professor Romata is sending messages through the question answer, so it means he's awake and up. And anyway, I hope he joins. If not, I have to thank George for leading this, and now to request him to put up the recommendations on behalf of the group for discussion. George, please.
George, I'm here, Omata.
I know you are there.
From the very beginning, I'm in the mood, so sorry about.
Okay, Masa, thanks. George, start, please. Izumi, please play the, yeah.
George, you're muted.
George, unmute, please. And
Unmute. Yeah, can you hear me now? Yes. I'm sorry, I was unmute. Thanks for the excellent talk of Alex, Minglong, and Grace. And as the panels evolves and the discussions, we have come to a few of the recommendations, and I will go through them. And the scoring has been done throughout the panel, but it is open for discussions, and I would like to present them to the audience. This is APASL, the HBV Reactivations 2021 Guidelines, our proposed recommendations.
Couldn't hear you, George.
Mute.
Yes, look out the mute.
Yes. Can you hear me now?
Yes, surely.
There are 5 clinical issues addressed by these recommendations. First, definitions of HBV reactivations. Second, who should be screened? Third, what will be screened? 4, management. And 5, liver functions monitoring. So first of all, definitions of HBV reactivations. Well, so throughout the literature, so there is a lot of heterogeneous definitions in terms of the viral loads, surface antigens, and ALT levels as the definitions of HBV reactivations. After reviewing all the literatures, and we come to these recommendations. Reactivations of hepatitis B, exacerbations of hepatitis B infections, surface antigen positive, greater or equal to 2 logs increase in HBV DNA levels from baseline levels. So the grading of the evidence is 2-2, and recommendation is strong. Detections of HBV DNAs with levels greater than 100 international units per ml in a persons with undetectable HBV DNAs at baseline. Grading of evidence is 2-2, and recommendations is strong. Reactivations of past infections and surface antigen negative, anti-core positive after the start of immunosuppressive therapy. Reverse surface antigen seroconversions, surface antigen negative becomes surface antigen positive. The grading of the evidence is 2-2, and recommendations strong. Appearance of HBV DNAs in the absence of surface antigen, HBV DNAs undetectables becomes the HBV DNAs detectables. The grading of evidence is 2-2, and recommendation strong. The second questions addressed is who should be screened. We set our recommendation is that all patients planned to receive immunosuppressive therapy should be screened. Grading of evidence 2-1, and the recommendation is strong. So the third question is what will be screened? The screenings we recommended should include surface antigen, anti-HBs, and anti-HB core. The grading of the evidence is 2-2 and the recommendation strong. For those surface antigen positive patients, additional tests for quantitation surface antigens and HBV DNA should be considered. The grading of the evidence is 2-2 and the recommendation strong. All surface antigen positive and surface antigen negative but anti-core positive patients should have the degree of liver fibrosis assessed by a hepatologist. The grading of the evidence is 3 and the recommendations is relatively weak. How about management? We recommend that it is mandatory and life-saving to administer prophylactic NUCs to the followings. In high-risk group, all surface antigen positive or surface antigen negative patients, but anti-core positive patients should be screened, should be administered nucleoside analogs. The grading of evidence is 1 and the recommendation strong. In moderate risk group, all surface antigen positive and those who are anti-core positive with advanced liver fibrosis or cirrhosis should be given prophylactic nucleoside analogs. So the evidence is 2-2 and recommendation strong. The preferred NUCs includes entecavir, tenofovir, or TAF. The grading of evidence is 1 and the recommendations is strong. How about terminations of the NUCs? We recommend that terminations of the NUCs should be considered 6 months after the completion of the immunosuppressive therapy. For surface antigen positive patients without advanced liver fibrosis or cirrhosis, the grading of evidence is 2-1 and the recommendation strong. For surface antigen positive patients with low level of HBV DNA less than 2,000 IU per ml before initiations of the NUCs. And the terminations of NUCs should also be considered 6 months after the immunosuppressive therapies in those patients who remain surface antigen negative but anti-core positive. The grading of evidence is 2-2 and the recommendation strong. Liver functions monitoring should be done every 12 weeks. In moderate risk group, surface antigen negative but anti-core positive patients with no advanced liver fibrosis or cirrhosis. The grading of evidence is 2-2 and recommendation strong. In low risk group, surface antigen positive or surface antigen negative but anti-core positive patients with no advanced liver fibrosis or cirrhosis, as related by Professor Grace Wong just then, grading of evidence is 2-2 and recommendation weak. If ALT is greater than 2 times baseline, we need to check surface antigen, HBV DNA, and treat with NUCs for those patients who have surface antigen seroreversions and or HBV DNA becomes detectable. The evidence is 2-2 and recommendation strong. This is the flow chart being modified based on the recommendations, and it's a summary. All patients who plan to receive immunosuppressive therapy should be screened. And all these patients should be screened for surface antigen positivity, anti-core, and anti-HBs status. For those patients who are surface antigen positive, tests for quantitations, surface antigens, and HBV DNA should be considered. And for all these patients, liver fibrosis assessments should be considered, and the risk should be stratified according to what Professor Yu Ming Nong has just alluded to us. For those who have high risk of HBV reactivations, NUCs should be given. For those patients with moderate risk, and if they are surface antigen positive, NUCs should be given. for those patients who have moderate risk of HBV reactivations, and if they are surface antigen negative and anti-core positive, but without advanced liver fibrosis or cirrhosis, we recommend monitoring of ALT every 3 months. However, if they have advanced liver fibrosis or cirrhosis, NUCs should be given. For those patients who have a low risk of HBV reactivations, if they are either if they are surface antigen positive or even surface antigen negative anti-HB core positive, without advanced liver fibrosis cirrhosis, we recommend monitoring of ALT every 3 months. And however, if those patients have advanced liver fibrosis or cirrhosis, we recommend administrations of NUCs. So this is the conclusions of our recommendations, and will be open for the discussions and the criticism. Thank you very much.
Thank you, George, and compliments to all of you for the hard work and the recommendations put together. I have a few questions, but first of all, I would like to give my own thinking because of some pressing concerns that I have. In your last slide and recommendations, we do not have any mention of the clinical course of the patient. You just have HBV reactivation and fibrosis assessment. But what happens to patients who get jaundice, ACLF, or would they require special consideration like liver transplant and others? So that part is missing in the previous recommendations. Patients MELD less than 20, 20 to 30, and more than 30 were the major debatable points. That is point one. And in the last slide, there are many other questions, but first was this. And also on the last slide itself, the moderate risk in those who are surface negative and anti-core positive and have no fibrosis, but they have moderate risk. Monitoring every 3 months is the question. Should we treat them or monitor them more closely? These were on the last slide, but I'll come to all. There are many, many concerns. And one more concern is on the diagnosis. A major concern is you say rise of 2 logs from baseline, but suppose you do not know baseline. Suppose there is a spontaneous seroconversion, and you have patient comes first time with jaundice. How do you diagnose? So this is the second question. If no baseline HBV DNA, how do you differentiate it is a reactivation or it is acute hepatitis B? So one of the strengths of our earlier data was that those who have got no baseline data, how much should be HBV DNA in them and how do you diagnose them? So out of all the studies, a DNA level of reactivation is generally higher than acute B. So I want you to consider 3 points. One on the diagnosis, if no baseline, clinical status. Third is on the outcomes and what is an ALT flare, because you have given 2 times. And I think Yunfen and others were very keen that it should be more than 5 times, while Americans were keen on more than 10 times. So what is an ALT flare? All these are major things in my mind, and then I will open it to questions. So first on the diagnosis, and I fire it on to George.
Yes, please. I really appreciate it. Well, these are very relevant questions, and obviously the guidelines needs to be something practical, and it has to serve the different communities with different social, political, and economical backgrounds. As you can see here, you consider MELD score and jaundice and those patients with poor liver functions. I think that the liver fibrosis, and that's why we want those patients with surface antigen positive or the with past infections detected to be assessed by a hepatologist with liver fibrosis assessment. And I think that with these inclusions, we will be able to identify those patients with poor liver functions to start off with. And it would be very unusual, as alluded by the Grace just then, if patients have poor liver functions, they have a normal liver fibrosis assessment with the non-invasive test, not just FibroScan, but also all the non-invasive measurements, and sometimes even invasive measurements and clinical assessment. And I think this might be more practical if we bring the liver fibrosis assessments into the context, because by then we I think in the practical sense, we would include those patients with poor liver functions, with poor marrow scores, and so on. Maybe the other panelist wants to throw in some comments.
This on the patient who has got jaundice, high ALT, would a non-invasive assessment or a better as a clinical indices of severity?
Yeah, the other panel members wants to throw in the comments. Ming Long is here. Grace, you want to make comments?
Omata from Tokyo. I think these guidelines are wonderful, and they maybe principally apply for the patients with going to have the other diseases, to receive the treatment. So, as Shiv Sari mentioned, no such a patient can be included in the guideline from the very beginning. So, if the patient is jaundiced, it's a totally different matters. So maybe this guideline is not that kind of the purposes. So maybe that's quite different from your situation.
And say these guidelines are meant for reactivation for patients on immunosuppression, then it is acceptable.
So just like the situation comes, new paradigm is like we are using a lot of PD-L1 antibodies. So as Dr. Stresser mentioned, maybe that should be also included because the guidelines depend upon the past literature in the past, but the ongoing ones in the clinical settings, and the guidelines should be addressed non-hepatologists. So maybe the simpler the better. But the effort and then the knowledge of the George Rao is beyond for everything. I mean, he being here for many, many years, nobody is really following the literature very much updated yet. But that may, bring the things to be a bit complicated. And then for general use, like oncologist or hematologist, I think our guideline can be simpler. So maybe 1 or 2 steps can be skipped. And then, for example, HBsAg titration, I don't use that. We just write straight into the HBV DNA detections, easily available. So maybe that can be simplified. Titration of HBsAg things in the past. So there are several small things, but as a principle, this is based upon the very wonderful, accumulation of the data in the past. The past means 40 years. That's my comments. Omata.
May I have the, Alice, you want to make a comment since you're here? I can see your face.
Sure, I really agree with the comments Professor Amata has just made. These need to be very practical clinical guidelines. And the focus of the guidelines is really not hepatologists because we know this and we're called in once the reactivation has occurred. The focus of these guidelines is for hematologists, for oncologists, rheumatologists, general gastroenterologists. And so they do need to be simple. I agree with that. And now that the hepatitis B drugs are generic, they're cheap, we know they're very safe, I think our threshold for using antiviral prophylaxis is reducing. So I think we can make them simple, both for surface antigen positive patients as well as isolated core positive patients. Professor Sarin makes some very good comments about about diagnostic categories, and I think we can address that in the guidelines. But the practical answer is going to be that that patient needs to be assumed to have severe HBV reactivation and needs treatment. And then you need to think about whether it's possible that there's a second cause of liver disease.
Now, talking about the immune checkpoint inhibitor, can I say a few words?
Yes, please. Louder, please.
Okay, George, can you hear me?
Yes, please. It's very important to review.
To be practical, I think there's one thing we probably have to mention, because in the past 4 years, we have run through a lot of checkpoint inhibitor for liver cancer, and now it's standard of care in the first line for advanced hepatocellular carcinoma. And there's one practical point. If a patient with a very high titer HBV DNA, and then can you start to treat them with checkpoint inhibitor? Because all the trials require very, very low titer, for example, either 0 or less than 200 to start with. But it's not practical. Many of the patients come to the doctor with a titer more than 1 million. Then you cannot wait to treat them until like below 100. It may take several months. So I believe we have to probably say a few words, because this is a very important point that a physician has to deal with every day.
Yeah, John.
Immune checkpoint.
About in risk stratification, if a patient has ALT levels, we would like you to give, because that is an impending worry. If the ALT is 5 times, 10 times, 20 times, I think in risk stratification, you are using more than 10%. I would like ALT to be somewhere, because the general clinician just uses bilirubin, ALT, and maybe clinical jaundice. The specialist will give you drugs, but I think we should have some clinical indices. So what is in your thinking?
Well, as I have said, we try to make it simple and not too complicated. But if we look carefully at the recommendations, if we follow all patients who receive immunosuppressive therapy, as alluded by Professor Yuming Long, and check the HBV serology, and if they are either surface antigen positive or anti-core positive, they already goes into a liver fibrosis assessment by hepatologist. And I suppose this would make things simple, because no, you don't agree with this.
The problem is you are talking from a virologist point of view, that you do HBV, you do beforehand. Here is a patient who has come with he's not been pre-treated. You understand? He is not pre-treated. He has not been screened. He is a reactivation or not? That's first question. You are giving guidelines for prophylaxis, for preemptive therapy. All these are well known. But what I am trying to impress upon, you are sitting in a clinic, or your colleague is sitting and the patient comes with icterus, or just have high ALT and he's a malignancy case. How do you address that? So that part is missing in this clinical assessment of a patient who is suspected. What you are doing is prophylaxis.
Already have liver disease. Yes, that's
prophylaxis. This is okay. Very good.
Yeah, I know. But you are saying that those patients already have liver disease, and
no, I'm not saying they present you with no prior history. He comes first time. He's not on prophylaxis or preemptive.
Yes.
He comes to you. How do you diagnose reactivation or an ALT flare, or how do you manage a patient who has come with suspected HBV? He's HBsAg positive. He has icterus or he has high ALT. He has received chemo or not received spontaneous. There is no mention of spontaneous reactivation in the whole guideline. So these are points which in my mind are to be considered.
Right. Shiv, I understand that. You are saying the definition of the reactivation. In that case, very simple. In order to use IgM anti-core, level of IgM anti-core may help you, whether it's a newly acquired or reactivation. So you are touching upon those things, but this is mostly the prevention of reactivation. But you are talking about, in general, how to make a diagnosis of reactivation in the textbook. I think that's a very important question, but I'm sure that George is not thinking about that.
Yeah, we are thinking about immunosuppressive therapy, not to talk about the spontaneous. So that would be, in general, hepatitis B guideline management. We are focusing on, because we need to have some, as I've mentioned, the clinical questions to be addressed, HBV reactivations, and in those patients who received plan or for immunosuppressive therapy. I totally agree with Professor Sarain that the importance of having those identified, but this is not within the scope of our current guidelines. Maybe others panels members have any thoughts to enlighten us?
Yeah, I have a few comments for Dr. Sarins just suggest. I think it's very important when we are talking about drug-induced reactivation, we have to take the control arm together. Because in the past, we are using TKI to treat liver cancer, and then we have placebo control. And we have seen same thing in the placebo control. That means spontaneous reactivation is something we have to, at least we have to count it in. And so again, in using immune checkpoint inhibitor, we have control arm used by TKI. So that means what happened in TKI is not immune related. It's something probably direct toxicity. But people may just consider the immune checkpoint inhibitor arm. Then they might think of everything as immune-related hepatitis, but that's not true. If you see what happened in the control arm, they have the same thing. So that's something we have to consider when we are trying to figure out the figure of drug-induced reactivation in addition to spontaneous reactivation.
Oh, maybe we can have a 3 set of guidelines, you know, because you are mentioning about drug-induced liver injury even, but the scope should be broadened if you include those things. So maybe part 1, part 2, part 3, and then beginning maybe what is the reactivation, what is the drug toxicity due to the drugs. I think, but the current situation we are talking about is prevention, prophylaxis, mainly focused upon. Otherwise, I think too broad to discuss about in a limited time.
Very brief point, because I have to leave in few minutes, is about a patient who stops taking drugs. He is on NUCs and he has stopped taking drugs, and after 6 months or so, he comes with a flare. He doesn't picture into your guidelines. You know, he was on TAF or Tenifo for 3 years. Now he has stopped. You are an anti-core positive, sorry, anti-E positive, and you have stopped his NUC in consolidation 12 months, 3 years later. He is off antiviral, and now there is a reactivation after some time of stopping the NUCs in anti-E positive patient. If that patient is also reactivation or whatever you may call relapse. Hence, I think our guidelines, either we title it, it is prophylactic for drug-induced, or it is only for chemotherapy or others, then it is perfect. I have very little to say. Even in that, I want ALT to be considered as an important marker, clinical jaundice. But if the other groups have to be included, I would certainly like some mention of that therapy. This is my opinion. Thank you.
This point is well taken and has been intensively discussed. In fact, when to stop the NUCs and so on. But this is just a general guidelines that we stop 6 months if it is just for the purpose of to prevent reactivations. But for those patients who cannot be stopped, they need to be continuous. That's why we bring the hepatologists into the picture, because they are going to decide when the patient is going to be taken off from the NUCs. If they need to be on the NUCs anyway, they have to be on the NUCs. We have to follow the HBV guidelines, or overall HBV guidelines.
Okay.
Yeah, but I think that the word is well taken, and Andy also brings it a very important issue. So, but the beauty of this guide.
2 or 3 more points. That is for Grace Wong, is about how do you monitor, how frequently will you be doing DNA or HBsAg tests, and the role of fibroscan non-invasive in a patient who will be jaundiced with raised ALT may be questionable, and we need more data to say about 12 or whatever. One more point is the patient has HBsAg positive, and you have finished chemotherapy. His ALT is normal, his DNA is undetectable, but will you stop therapy in him 6 months or 12 months later? So he is reactivated but has not made anti-HBs.
Oh, this is exactly the recommendations. We need baseline HBV DNA to decide, but the ultimate decisions is
DNA is negative, but HBsAg remains.
No, the DNA negative when you with the NUCs is different. So before we start the NUCs, we have to have the DNA before we start the NUCs.
Stopping rule. The question is a stopping rule after chemotherapy is finished. 6 months later or 12 months later, the person is DNA negative, but HBsAg is positive.
We might continue if they have advanced fibrosis or liver cirrhosis, or if the HBV DNA is at the baseline before the initiation, so the NUCs is greater than 2,000. That's within the recommendations. But this is all. But as we have mentioned, so it has to be the decisions by the hepatologist. Some hepatologist needs to come into the picture.
And my last comment before I leave to all first compliments and thanks is I think we should address in a manner unanswered questions. You know, what
Yes.
is, I would like a large section to be added on to, you know, what people commonly ask. You can see so many questions. They're all jumping every time. I think we should say what we don't know and what are the research areas, you know, like, okay, we don't know everything. We have to have a new guideline in 3 years. So what are those areas which you would like to consider and are contentious and you want cohort studies or whatever it is? So please leave open the new areas. This is my
Professor Serene, can I say something? Can I jump in here, please?
Yes, Sid is here.
This is Saeed Hamid from Karachi, Pakistan. So I entirely agree with Professor Serene, Professor Lau. The thing that is missing from these guidelines, and I hope this is not just immunosuppressive therapy, what is missing when we are in Asia Pacific is the HBV-HCV co-infections. Asia Pacific carries 70% of the burden of hepatitis C. There are large treatment programs that are moving in Asia Pacific. So there are programs in India, there are now programs coming on in Pakistan. Egypt has already treated about 453 million people. So there is a large body of evidence that is collecting. There is a huge denominator now. And I think Asia Pacific can answer some of those questions that are around the HBV approach to hepatitis B in large treatment programs, public health programs that are dealing with very large throughput HCV patients, right? And this then comes to preferences and values, resource availability, etc., etc. So I hope that even if we don't make a recommendation, we can have a section where we can, you know, put in this data, give some expert opinion, etc., etc. This is, I think, is critically important for the region. Thank you.
Okay. Thank you all, George, and all my colleagues, and apologies for leaving early, but a great effort, but many more miles to go. Thank you. Thank you all.
Thank you, everyone.
Professor Amata, you want to make a last comment on the sessions?
Well, I really want to see you, everybody. Rosmawati, Gani, and Dogmeji, and then Thompson, and Lin Cheng. I want to see you face to face in the future. I think get vaccinated, please. Yeah, but this is a wonderful session. I believe this is one step forward, no question. So please make a print out of it so that everybody can use it. Thank you very much, George Lau. Thank you, everybody. Yeah. You, Mindy, you. Hi.
Hi.
Grace, wonderful. Rosmati.
Very nice to talk to you.
Dogmeji, you. Gani sensei. Gani sensei.
Also, thank you very much.
Yeah, thank you.
Especially Professor George Lau.
Yeah, wonderful, George. You study a lot. Good student, University of Hong Kong.
I'm still smiling. Well, last thing, I can see a lot of questions on the chat box.
Yeah.
I would respond later on because we have a limited time on these sessions. And could the Secretariat pass on the questions and I can respond appropriately.
Right.
This is important for writing up the manuscript. And we look for
200 participants. 200.
Recommendation published by April this year.
Right.
By Pathology International. Thank you very much.
Good. Very good. All right.
Have a good day.
Thank you. Bye-bye.
Thank you, Josh.
Thank you very
Thank you,
much,
George.
George.
Thank you, everyone. Bye-bye. Bye-bye.